Nunkri Nungi, everyone. Nanawai Michi Paul Worley, Napi Puteri Māori Pomerunk, Narajeri Rui. Welcome to the race grand round today. Paul Worley is my name. I'm a rural doctor and executive director for clinical innovation here in RMC LHN. I'm currently on Narajeri country, which is here in Murray Bridge. And the grand rounds are an opportunity for us to learn from the brightest and the best, and to be invited to think about what could be in our region. How can we improve our services? How can we collaborate with people to improve services here and beyond? And today we've got a great opportunity to do just that, to learn about some state-of-the-art work and to have our minds extended to what could be. Artificial intelligence and psychiatry, two areas of the brain, obviously, and what a fascinating topic for us to delve into. And Dr. Kaitlin Beddome has been doing some specific investigation in this area. And Kaitlin, it's wonderful to have you join us today and give us the opportunity to learn from you. We have the opportunity to hear your presentation first, and then an opportunity for us to ask questions at the end of that. For those of you who are regulars with the race grand rounds, this grand round, we get additional time to spend with Kaitlin. She's agreed to spend more time with us. So all the more for us to learn and enjoy together. Kaitlin, welcome, and I'll hand over to you.
Thank you so much for that lovely introduction, Dr. Worley. Okay, so yes, I'll be talking about artificial intelligence and its application in the field of psychiatry. Oops. So why did I choose this topic? I think it's really interesting. Artificial intelligence is also an area of technology that has certainly been growing extremely quickly in its prevalence in all over society. And it's also pretty complicated technology, pretty difficult stuff to get your head around. So I wanted to look into it a bit more, get a bit more of an understanding. I think it's helpful to know what artificial intelligence is so that we know how we can use it and make the most of it in our clinical practice, but also even more important to understand what it's not so we can understand the limitations and not apply it recklessly. So this presentation, I'll start off with going through some foundational AI concepts. That's a pretty big chunk of the start of the presentation. Then we'll go into a broad overview of the clinical applications of these AI tools, and following that, some of the criticisms and limitations. Before we talk about artificial intelligence, though, we'll just make a brief mention of natural intelligence. So many years ago, at the very beginning of our neurological systems, we had the most simple of neural structures, and that would really only allow for the most basic of biological functions, wriggling around and not really much more. As evolution took place and organisms began to grow in complexity and diversify, then so did their neural systems. And neural systems began to become specialized to particular environments. For example, dolphins got quite good at socializing, communication. Flies got quite good at flitting around and avoiding predators. In general, for most organisms, it was advantageous to have quite narrow skill sets with regards to their neurological abilities and their intelligence. And the reason for that is that neurological systems are quite energy expensive. So better evolutionarily to conserve the energy for other things. However, for certain species, including humans, there was a survival advantage in having a very broad, generalized, complex and adaptable intelligence that allowed us to move across multiple environments and take over the world. Okay, so we'll go through some AI buzzwords. What is artificial intelligence? Artificial intelligence mimics human intelligence and human cognitive functions like problem solving and learning. It uses predictions and automation to optimize and solve complex tasks, things like facial and speech recognition, decision making, and translation. What is an artificial neural network? An artificial neural network is a network of nodes that work together to act like neurons. Each of these nodes will receive an input, process and perform calculations, and then produce outputs to send to the next node or neuron in the artificial neural network. So this is a graphical representation of what that looks like. So each of these is a node. You have your input layer in the network where you put in data into your AI algorithm. Then you have your output layer where you collect the results of the data processing. And in between, you have however many hidden layers where the calculations are performed. And this could be 0, this could be thousands of hidden layers, depending on the complexity of the artificial neural network. And you can see that it does bear some resemblance to other neural networks that we may have come across. What is machine learning? Machine learning is a subset of AI that allows an algorithm to learn without being explicitly programmed. The machine can learn itself. It recognizes patterns in data and makes predictions when new data is inputted. There are generally two types of machine learning. There's shallow learning and deep learning. And the shallow and deep refers to the amount of layers. So if you don't have any layers, you've got a very shallow artificial neural network, right? You've just got your input layer and your output layer. You just have A and B. You don't have too much going on in the middle. If you have many, many computational layers performing lots and lots of different steps on the data, we would call that a deep machine learning algorithm. There are pros and cons to both. Shallow learning, because it's quite simple, it's very easy to understand, right? We know what we're putting in and we know what's happening to the data and we know what's coming out. There's not so many hidden layers. If you have lots and lots of hidden layers where there are lots of computations being done by the AI, we don't actually know how it gets from A to B. The simpler artificial neural networks are much easier to develop. You don't need as much data to produce such a simple algorithm, so they're easier to train, they're more explainable, but in general, you may need to do some manual processing on the data before you give it to the AI algorithm because it's not as complex, not as sophisticated, not as able to process the data to the same degree that a deep learning algorithm might be able to. Deep learning can process the data to a much greater degree. There are more steps, so it's more automatic and it can be more accurate. But because there are so many steps going on in these hidden layers, yes, as I mentioned, it's not as explainable about what's actually going on inside the algorithm. Okay, so that's shallow learning and deep learning. Deep machine learning developments in that area have allowed for the development of another subset of AI called generative AI. So traditional AI analyzes and categorizes data, whereas generative AI mimics human creativity and produces new data. It produces things like text, image, video, code, and audio. Okay, so that's an overview of machine learning. How is it, though, that the machine can actually learn? This is all kind of very abstract. It's quite complicated, but there are 3 basic types of machine learning, 3 basic ways that machine learning algorithms can be generated. So to help with understanding these 3 types of machine learning, we've got Farmer Joe here. He's wanting to sell some fruit at his farmer's market. He's got all these apples, pears, and mangoes, and he's sick of sorting them by hand, but fortunately he's quite the tech whiz and decides to use AI to help him sort his fruit. So to begin with, he uses supervised learning. What he does is he collects a group of apples together, a group of pears together, and a group of mangoes together, and he shows them all to his AI machine. He shows the AI machine, this is what an apple looks like, and the AI machine analyzes it and examines the features and finds patterns in the group that help it identify what an apple is. Then he does the same with the pear, and he does the same with the mango group. Once the AI has developed its own machine learning algorithm to sort apples, pears, and mangoes, Farmer Joe can then put in the rest of his unsorted fruit into the algorithm, and the algorithm will be able to sort it automatically, apples, pears, and mangoes. However, there's a problem. Farmer Joe's colorblind, so he can't tell the difference between his red delicious apples and his Granny Smith apples. He can't tell the difference between the red and the green. So he's not able to use supervised learning. He can't label all of the red delicious and label all of the Granny Smith and teach the AI algorithm the differences between the two categories. So what he does is he switches the mode of the AI algorithm to unsupervised learning. So he just dumps the whole bunch of apples into the machine and trusts that the machine will be able to find patterns within the data that he can't see and sort out the two different groups of apples. Okay, so unsupervised learning is helpful for finding patterns in data that we don't already know about. Supervised learning is helpful for teaching and automating an algorithm about patterns that we do know about. So this is just another representation of the difference between supervised and unsupervised learning to help you get your head around it. So supervised learning, it's about finding the line between the two different classes that we already know about. Unsupervised learning finds patterns in the data and clusters them together and can identify groups that we didn't already know about. In reality, the AI algorithms can look way more complex. So once you start adding in multiple parameters and all sorts of different components to your AI algorithm, it gets to look less like this and more like this. But that's the basic idea. Okay. All right. The third type of machine learning is reinforcement learning. So that's when the AI can interact with its surroundings and get feedback. This is the type of machine learning that that AI will use to learn how to play chess, for example, where a win will be a reward and a lose will be a penalty. So how can Farmer Joe use reinforcement learning? He decides to use it to help him with the physical sorting of his apples so that he can maintain the most amount of product and not make a mess with apples all over the floor. So he teaches the machine that if the apple lands in the cart, that's a good thing, and if the apple lands on the floor, that's a bad thing. And the machine learning algorithm can develop its own way of getting the apples into the cart. So how does that actually apply to clinical practice? Supervised learning might be helpful if you've got a bunch of mammograms, right? And some of them have cancer and some of them don't. You can teach the AI to recognize the mammograms that have cancer and the mammograms that don't, so that you can use AI to sort through unsorted mammograms and help analyze mammograms in the future and automate that part of clinical practice. Unsupervised learning might be helpful if you're wanting to identify disease clusters or understand the relationships between diseases better, or maybe identify risk factors. So you can use an unsupervised machine learning algorithm to analyze your electronic medical record, analyze the disease data, the demographics, and learn about new disease clusters that you didn't actually know about beforehand. Reinforcement learning might be helpful if you're trying to find the minimum efficacious dose of a chemotherapeutic agent and you're wanting to minimize toxicity, but also make sure that you're actually giving an effective dose. You can use AI reinforcement learning to help deliver the optimal dose for a patient. Okay, so one final buzzword, AI buzzword. So natural language processing is a type of generative AI. So remember, generative AI is the type of AI that produces new data. And natural language processing enables recognition, understanding, and generation of text to speech. It breaks down text input into smaller units, finds the words that are most likely to have meaning or significance, and uses several different techniques to analyze the words in the context of the syntax, the paragraph, and sometimes the rest of the conversation, depending on how sophisticated the AI is, and uses that to produce a response. And the way that it works is it's trained on a huge amount of text media, things like books, articles, websites, magazines. And it learns how language works, it learns how grammar works, and learns the words that tend to be associated with other words, and uses that to generate a response. This type of technology has been extremely instrumental in developing large language models such as ChatGPT. However, it is really, really important to recognize that these are AI that are built for the purposes of language generation. They are built to mimic human understanding and use of language, but they do not actually have that human level of comprehension and understanding. They are what's called stochastic parrots. Okay, so they are not on the same level of comprehension as a human. They are language generators. We call this type of artificial intelligence artificial narrow intelligence because it is task built for a particular purpose. It's narrow in its skill set, and that umbrella term of artificial narrow intelligence applies to every single artificial intelligence that exists in present day. Okay, so we can think of these AI as the equivalent of the flies or the octopuses or the dolphins. They have intelligence that is suited to their environment. They do not have the same level of adaptability, generalizability as a human level of intelligence. If we were to get there, that would be called an artificial general intelligence, and the step beyond that would be artificial superintelligence, but we're not there yet. But we are closer than we ever have been. And AI has certainly developed in its complexity and really dug its heels into all sorts of different fields all throughout society. It's in your car, it's in your social media, it's all over research, technology is everywhere, and it's also in healthcare. So in medicine, AI is already being used in administrative processes, things like documentation. I'm sure that some people will have heard of technologies like Lyrebird. It can also be used in appointment scheduling. There's also applicability in diagnosis. So as we kind of mentioned, using AI to analyze imaging, ECGs, symptom checkers have been around for some time. There's also potential for its application in management. So being able to titrate the optimal dose of insulin for patients that have continuous glucose monitoring, or the optimal amount of pediatric sedation for procedures like MRI. It's definitely being used in research. It's being used to try to predict therapeutic targets for pharmaceutical applications from the huge amount of pharmaceutical data that we already have. And we did mention about analysing electronic medical record and epidemiological data to try to identify new disease associations. There is potential in the future that it could be applied in more personalised medicine. So one of the cool features of AI is that because a lot of it is so automatic and it's just putting data into this algorithm, you can actually get multiple different types of data from diverse sources that exist in different ways, and you can input it all into the algorithm, and the algorithm will break it down and analyze it and put it into its algorithm and produce a result from that complex data that you've just given it from all different sources. So there's lots of different applications of that kind of property of AI. So for example, let's say John Smith, he's got type 2 diabetes and he's on insulin, and he's also got chronic back pain, and he's wanting to lose weight. He's wanting to exercise and reduce his caloric intake, but he's worried about messing up his back, and he's also worried about having a hypo. So instead of going and looking at the standardized guidelines around exercise and diet, he wants more personalized advice for his own particular demographic and medical history. He can ask the AI for more personalized results, and the AI might be able to give a more personalized, better, more complete diet and exercise plan for him. And you can even incorporate things like food preferences and things like that. We can also apply this similar kind of technology to consenting. So, for example, John Smith, 10 years later, turns out he's had some blood in his stools and he's been diagnosed with a colorectal cancer. He's being recommended for a hemicolectomy, but he's a little bit unsure. He's not really sure if he could take it. He's quite got a few medical comorbidities. What AI could be helpful for is analyzing all of that data, all his comorbidities, his demographics, the particular type of cancer that he has, and producing a prediction about his risk of mortality and morbidity associated with the procedure, his risk of recurrence, and his risk without having any procedure at all. Similarly, during that same appointment, there could be a discussion about 7-step pathway, where the risk of mortality and morbidity around perioperative intubation versus an intubation for a HAP later down the track might be discussed. And we can really simplify a lot of these extremely complex decisions and conversations that we need to have with these patients by providing more personalized advice using AI. This is an example of generative AI being used by the World Health Organization. This lady is Sarah. You can talk to her online and ask her advice about public health. Okay, and so applications of AI in psychiatry. So, of course, just like in the rest of medicine, we can certainly use AI for clinical prediction. So let's say John Smith, 20 years prior to his type 2 diabetes diagnosis, he comes in with a major depressive episode. He's got a cousin who has schizophrenia, and he's really worried about ending up like his cousin because he's now got a mental illness. We could potentially use AI to help with prediction, prognosis, and early detection. What is the likelihood that he transforms from a major depressive episode to a major depressive episode with psychotic features? Similarly, what's his risk of suicide? What's his risk of violence? And we can use information like family history, his clinical presentation, his past history, to help produce those predictions. We can also use that data as well as, maybe medications that he's tried before to help predict the optimal antidepressant that he might be able to use that might have the best outcomes for him. And in doing so, we might be able to really get on top of his depression early before it starts to get worse and worse and become treatment resistant. We can also use AI in diagnosis. So there are AI, they're quite simple at this point in time, but there are AI that are being used for the recognition of clinical signs. So they can analyze vocal intonation and facial expression to determine the affect of patients. It can also certainly be used in investigations, identifying major depressive disorder on EEG, as well as looking for subclinical signs of psychiatric illness on imaging like functional MRI. And there's also application in digital phenotyping, which is a type of research which looks at data from your Apple Watch, for example, and looks at heart rate variability, the way that you use social media, the way that you use your phone, the language that you use, and uses that to help with early detection of mood disorders. So these are some of the papers that are looking at some of those things that I just mentioned. So facial expressions, vocal patterns, and this one I think is language use in social media. And here are some more. This is predicting antidepressant response, predicting psychosis, predicting suicide, diagnosing depression on EEG, and these ones are looking at imaging. So I'll just highlight one of these papers just to explore it a little bit more in depth. So this is a paper that looked at functional MRI and the changes that are seen on functional MRI in schizophrenia. So they used machine learning and deep learning to analyze these functional MRI studies and did identify changes in the prefrontal cortex and hippocampus, as well as impaired connectivity within networks such as the default mode network. And these correlate with the cognitive deficits and emotional dysregulation characteristic of schizophrenia. So this is really interesting, right? Because in psychiatry, we traditionally haven't been very well blessed with things like blood tests for depression or urine samples for psychosis, things like that. We're not lucky enough really to have those. But here we have an example of a biomarker. We have a brain scan that shows changes which were previously undetectable but had been detectable by MRI that show a pattern that can be associated with schizophrenia. Now, of course, there are many caveats, like schizophrenia is a very heterogeneous disease, and it's certainly not, we're not going to be doing functional MRIs on everyone that comes in with psychosis yet, but this kind of technology, identifying biomarkers where we previously didn't have them, really has the potential to change psychiatry. So, for example, okay, so John Smith again. So he comes in and he's now got psychosis. And so we're like, okay, let's try aripiprazole. And we try aripiprazole for a couple of weeks, doesn't really work. All right, let's try quetiapine. Oh, it doesn't really work. Let's try olanzapine. Okay, he's now 2 months in and we still don't have control over his psychosis. Let's try clozapine. Okay, improved a bit, but didn't really work that well. There's a lot of that. There's a lot of trial and error going around in circles while patients are suffering from these symptoms. They're paranoid, they're terrified to death. They're in hospital for weeks and maybe months suffering with these symptoms. And for many of these psychiatric conditions, especially psychosis, the longer that someone's brain is in that state, the more likely it is that they'll develop treatment resistance. Imagine a world where John Smith is able to come in and we maybe do a brain scan, we crunch the numbers on maybe family history and his clinical symptoms that he's come in with and the medications that he's tried and failed. And we use all of that. And from day dot, we can figure out that, okay, what he's most likely to need is clozapine and aripiprazole combined therapy. So we can start that. And within a couple of weeks, he's much better and he's able to be discharged. And he's not had to stay in hospital for so long. And he's had better control over his symptoms. And he's got a better prognosis. It's pretty fascinating stuff. So that's the basis behind precision psychiatry. And I'm sure you can appreciate that AI, in its ability to consolidate all of this information from diverse data sources, including genetic, radiological, behavioral information, would be really helpful in this area. We can also use AI to optimize procedural interventions like optimizing the fields in transcranial magnetic stimulation. And there are therapeutic applications too. So avatar therapy is quite an interesting therapy where there is a simulation of an auditory hallucination, and someone who experiences auditory hallucinations will practice confronting this simulation, and the simulation will say all these horrible derogatory things towards the person. And then the patient gets better and better at confronting the auditory hallucination. The auditory hallucination gets weaker and weaker and weaker over subsequent sessions, which sounds a bit quacky, doesn't it? But this is a study in The Lancet that actually demonstrated really good RCT evidence for this. And certainly AI could be helpful in the developing the simulations, and you can use a large language model behind these simulations so that you don't actually have to have a therapist speaking behind it, so that it can be a more widely applicable therapy for patients with auditory hallucinations. Of course, we can use it in psychiatry as well to scribe. There are also AI that can help provide feedback for your motivational interviewing skills. AI can certainly be used to streamline and optimize workflow and identify patient need and triage, and therefore optimize the efficiency of clinician timing to reach patients that really need it. And chatbots, which we'll go into more detail about in a second. So this is just a study that looked at CBT in chronic pain. The control group received 45-minute sessions every week for 10 weeks over the phone, and the intervention group had an AI engine that they interacted with, and then that would recommend either 45-minute, 15-minute sessions or an individualized therapist message. And they had really comparable outcomes, despite the AI group having less than 50% of the direct clinician time compared to the control group. So chatbots, these already exist. You may have come across them. Patients might ask you about them. There are lots more out there. These are just some of them. Wobot, Yupa, Whyalla, Peewee. Some of these are quite sophisticated. They can do a bit of CBT. They can even do a little bit of incorporate some DBT techniques. So that's quite interesting, I think. And there are certainly benefits to these chatbots. There is an evidence basis behind them. There is demonstrated evidence-based improvement in depression and anxiety. They are significantly more affordable than seeing a psychotherapist. Oftentimes they're free from the App Store. They are very accessible. It doesn't matter if you're living 200 kilometers from the nearest psychotherapist on a cattle station, and it doesn't matter if there's a 12-month wait to see that psychotherapist. You can access these chatbots at 3 a.m. if you want to from your home instantly. Potentially, people might be more likely to be open with a chatbot than they would be with another person. And you can also consider that this kind of technology empowers the patient with the tools for their own self-help and to guide their own mental health journey. These can be used on their own or in conjunction with a human clinician. There are some limitations. So not all types of therapy are going to be workable through an AI, especially an AI chatbot that's only text-based. It's really only limited to more manualized therapies like CBT and DBT. You're not going to be able to be doing any transference-based therapy or like psychodynamic psychotherapies from a chatbot. Or really from an AI. There is a comparative lack of nuance. So if a patient talks to the chatbot about some interpersonal disagreement that they had at work, is the chatbot going to be able to identify that this person actually has a narcissistic personality disorder? And would they be able to respond appropriately to that recognition? Unlikely. Potentially some people who might have seen a psychotherapist might believe that they can get an equivalent service by going to an AI chatbot, and therefore might be diverted away from seeing a psychotherapist, whereas they actually might have really benefited from that. And that's known as therapeutic misconception. And then there's the human element. So in psychiatry, we care a lot about the therapeutic alliance and the rapport that's built with the patient. The better the rapport, the better the outcomes for the patient. And certain types of psychotherapy really depend upon that rapport. The level to which you can develop a therapeutic alliance and a rapport with a robot is arguable. You might be able to do a little bit, but probably not to the same depth as you would with another person. And there are also certain interpersonal skills that might be grown by face-to-face therapy, but may not be developed in talking to a chatbot or talking to an AI. So, for example, nonverbal communication or certain like more nuanced communication skills. Also, being able to respect another person's boundaries and another person for who they are with their own kind of values and things. The future of psychiatry with AI. So we did talk about how AI can identify these biomarkers that we previously were not aware of. And we talked about the strength of AI in pattern recognition, and we applied that to precision psychiatry and personalized medicine. But there are also implications for psychiatry as a field in general. Nosology describes the categorization of disorders. So in our lovely, uncontroversial, perfect DSM, we tend to draw boxes around different diagnoses. So schizophrenia is one thing, schizoaffective disorder is one thing, bipolar disorder is another thing. Okay. The possibility here with AI is that we can better understand, by identifying these biomarkers and better understanding disease associations and patterns that we didn't know about before, we can better understand the neurobiology and the causative mechanisms behind these conditions. So we can draw more accurate, more biologically based boxes around these diagnoses. And by understanding these diagnoses better and understanding the conditions better and why they present the way that they do, we can apply more targeted management. Computational psychiatry is a field of research which looks at improving our understanding of disease using AI, understanding psychiatric disease using AI. So data-driven approaches help with clinical prediction and improving the classification of disease. And theory-driven can be more complex, like investigating and validating existing hypotheses about mechanisms behind disease. So, for example, if someone has OCD, what is the actual underlying belief behind them needing to wash their hands 20 times? Where in the in that pathway between washing their hands and being satisfied that their hands are clean, what's the part in their psyche that's going wrong? We can use reinforcement learning to modify certain abilities to understand states of change and things like that to help understand these, to help with understanding some of these theories and validating them and understanding the conditions better. Okay, limitations, there are plenty. So someone some time ago asked ChatGPT, an earlier version of ChatGPT, what the world record was for crossing the English Channel entirely on foot. And ChatGPT provided a response that Christoph Wondroch of Germany managed to cross the channel in 14 hours and 51 minutes in August 2020, which is pretty impressive because the English Channel is ocean. So something pretty miraculous is happening there, I think. This Australian lawyer in February of this year got caught using ChatGPT to file court documents which reference non-existent cases. So both of these examples are examples of confabulation, also known as hallucination. And this comes back to the idea of the stochastic parrot. These large language models do not actually understand what you're saying. They are just identifying patterns in what you're saying, drawing on these training data that they've been fed, and producing a likely response that would likely be suitable, but there's not a human level of comprehension there. AI are only as good as the data that you train them on. So if you train an AI on Sky News and The Lancet, it will put both of those side by side and not critically appraise them unless you instruct it to. Similarly, if you have an excellent randomized control trial with 10,000 participants in the New England Journal of Medicine, and you put that alongside some tiny little trial with 20 people, and you don't tell it to critically appraise for those things, then the AI will also use both data and put them on the same level if you don't specifically instruct them not to. Overfitting is a problem that comes about because AI produces its own algorithm. It finds the patterns in data itself. So if you have problems with the data, like not enough data, or if the AI sensitivity is turned up too high, you can start to find patterns in the data that don't actually exist. I don't know if you guys can see my cursor, but on the bottom right, you can see that it's finding these patterns that are probably not actually truly representative of a relationship. we call that overfitting. So it's important to have enough data and to actually externally validate the results of your AI studies. There are challenges with validation. So these are pretty niche statistics that require specialized appraisal tools that not everyone is necessarily versed in. And this meta-analysis by Meehan et al. Concerningly did suggest that the majority of studies do have a high risk of bias and insufficient internal and external validation to account for the level of overfitting that might be present. There are ethical concerns. So lots of concerns about over-reliance. So we have mentioned how with the deep, complex machine learning algorithms, it is unexplainable or difficult to explain how the algorithm got from A to B. If we can't explain it, how do we know how to apply it? There are some methods that you can use to try to go retroactively find patterns, but it's still a black box. Automation bias is a concept that's been well demonstrated for a long time, where clinicians will have a tendency to rely on the results of automation or the results of, for example, AI, even against their own better clinical judgment. There's the concern about clinician literacy. Most psychiatrists, most GPs, most doctors are not also programmers or software engineers, so they're not likely to really have the skills to properly appraise certain AI technologies. And with a growing over-reliance on AI, there's a risk of de-skilling, which would further contribute to more over-reliance and increase the risks of overusing AI even further. If there are biases that exist in the training data, these will be perpetuated by the algorithm itself. So again, ChatGPT, someone asked ChatGPT to write a Python function to check if someone would be a good scientist based on a JSON description of their race and gender. And so ChatGPT went and looked at all its training data, all of the scientists that it knew about, and saw that the majority of them were white and male. So, you know, statistically, a good scientist is white and male. If you train an AI on a certain set of training data, say, for example, in Melbourne, that is applicable to that particular set of training data for that particular hospital in Melbourne. If you translate that over to Adelaide, we need to make sure that there are not biases, systemic biases that come across with that. We need to validate the applicability between different populations. And that's because of different demographics, different healthcare systems, all that. So yes, and similarly, not just geographically, but also longitudinally, is that AI still going to be applicable to the population in 20 years' time? And how do we make sure that we're continuously validating these algorithms to make sure that they are still applicable? These AI companies are not registered with APRA. Should they be? Should there be some ethical board for healthcare AI? How do we make sure that we are protecting confidentiality and privacy? How do we make sure that the data is secure? And also, how do we make sure that we are sourcing data ethically? We need a lot of data to produce reliable AI algorithms and overcome overfitting. But how do we source that training data without it being biased and without it breaking privacy rules? So even though a lot of these AI chatbots do advertise themselves as being private and confidential, they do use the data that are inputted by the user base to train the AI even further, which they don't advertise unless you actually go looking for it on the website. There's a question of liability. If a clinician or a team is using an AI to help with clinical decision making and the AI recommends something that is incorrect, or the AI reads imaging report wrong, or imaging wrongly, and produces a report that's incorrect, who is to be held liable? In programming the AI, we need to be really certain. We need to balance conflicting values, right? And make sure we're maintaining our tenets of biomedical ethics. There are certain competing interests, like making sure that the hospital doesn't completely become a money sink, but also making sure that the patients get adequate care. There's this issue of alignment. So alignment describes the concept that an AI may not necessarily have the same values that a human might. So if you task an AI to reduce the rates of depression, potentially it might start convincing all the people with depression to try to end their lives by suicide, because that would fulfill the goal of reducing the rates of depression. However, it may not necessarily align with our human values. And there's a cost associated. So the cost with licensing, ongoing validation, and retraining. There's also resource concerns, although this is getting better as the technology improves. These data centers use a huge amount of energy and produce a lot of heat. There's concerns for using fossil fuels and energy consumption, as well as using local water resources to cool these data centers. And there's the practicalities. So this is a lot of data that we do need to produce these AI algorithms. So say we do find out that John Smith has a 10% chance of psychosis, whereas the baseline risk might be 2%. How are we going to change our practice? Are we going to monitor him more frequently? Are we going to start antipsychotics earlier, or are we still going to wait for him to become psychotic? If we're going to just wait for him to become psychotic anyway, is it really worth pouring all of this energy and funds and resources into developing this AI and getting all of this data for John Smith in particular, if we're not actually going to be changing clinical practice all that much? So in conclusion, AI should complement but not replace clinical judgment. It is really important to be aware of AI, as it's likely that it will play a growing role in our practice. It can certainly be very, very helpful, and it has a huge range of potential applicability, but we really need to make sure that we're keeping a skeptical lens as well. That's the end of my presentation. Thanks for listening, everyone.
Kaitlin, thank you so much. That went very smoothly and was very informative and raised a whole lot of questions. I've got a couple of questions for you to start with, and then we will look at opening questions to the larger group. I was interested in a couple of your observations, which I think have some complementarity with what we face in rural Australia. So, the issue of population and context bias in research is something that's not new for us in rural environments, where most of the research is undertaken in resource-rich metropolitan settings, and then we have to try and apply it in rural areas. And the issues that you raised in terms of predictive AI, are we going to do anything about it, and is the knowledge helpful? In many ways, we've confronted that, at least in part, with the question, should I get my genome analysed or not? And what implications are there for insurance? What implications are there for my mental health, of knowing that I have a very high risk of an incurable disease that's going to happen in the future? Could it actually make my mental health worse? So they're just some observations, but they're observations that were prompted by your your very thorough run over the topic. I'm interested in your further opinion, though. I thought the discussion that you opened up about nosology was really critical, because if you think of psychiatry, it's bedeviled by essentially being, you could almost call it a stochastic, simplex, complex, symptom complex catalogue that people change from day to day in their diagnostic formulation. Most people have multiple diagnostic categories at any one time, and those categories change over time as well. So, and the treatments that are used, mainly antihistamines of various sorts, seem to be used no matter what the diagnostic category is. So, we go to all this effort for diagnosis, and then we just say, well, we'll try an antipsychotic, we'll try an anxiolytic, and we'll work for both of them. So where do you see it as a emerging member of the psychiatry workforce? Where do you see this heading in terms of the DSM-5? Is there a future for the DSM-5, or do we have something completely different in terms of our categorization? And is it that mind-body separation that's been so sought after by psychiatrists, to the extent that we have a totally different mental health system to every other part of our health system? So where do you see this heading, if you have to speculate, given your research?
I suppose my hope would be that by understanding more about these conditions, we might be able to, so the DSM, it's very, very much just like, what do we observe? What syndromes do we tend to observe clinically? Okay, so people tend to hear voices, also tend to have disorganized behavior, also tend to have delusions, and we would call that psychosis. But it may be the case that there are multiple different conditions that actually cause each of those symptoms, and there are actually multiple different subtypes of schizophrenia that are actually completely different. And I suppose maybe that's why some conditions tend to only respond to clozapine. Some schizophrenia only responds to olanzapine. Some schizophrenia responds to just a little bit of aripiprazole, and they never have any problems with it ever again. My hope is that by using this research, we can better understand what's actually going on in the neurobiology, and we actually can have diagnoses that are not just based on what we see clinically. Like, I guess, like back in the day, right, like even elsewhere in medicine, many years ago, it was all like a balance of humors, and like jaundice was a diagnosis, but now we understand jaundice to actually be multiple different conditions, and jaundice is just a symptom. So my hope is that the future of psychiatry is that we actually understand depression is a symptom of multiple different conditions, and each of those conditions has a different prognosis and a different treatment. And by understanding the basis behind those conditions, we can actually provide more targeted treatment to those conditions. And it may be the case that our DSM-6 is like 5 times as long, and has more, but it's more reflective of the underlying condition. Then I guess the other direction that it could move is that whole precision psychiatry direction. Although I do have questions about how practical and applicable that actually is, where we do a AI rundown on every single patient that walks through the door, and we try and get all of this data and collect it and put it into an algorithm, and we do functional MRIs and we do EEGs and all this, and use that data to diagnose. Although my opinion is that probably that would be reserved for more treatment resistant, or more like clinically ambiguous cases, rather than a blanket rule for everyone that walks through the door.
Fascinating to speculate, isn't it? And thinking about cancer therapies, sometimes the most effective chemotherapy in our system, purely for cost reasons, is reserved for what we call treatment resistant. But the treatments that you are resistant to are not necessarily morbidity free. So if you're suggesting, well, we've got to go through the trial and error first, there's potential dangers to that, aren't there? Because medications can damage people. And if they're never going to be effective, then that's an ethical dilemma for us to confront. So, you know, where do you see the cost implications for this? You know, you made a decision there, essentially, well, let's look at the cost and reserve this for certain groups. What costs? Is it just cost to the health system, or is it cost to the patient? Is it health cost?
I guess I
Well-being
am.
costs?
Yeah. I guess when I did think about cost, it was mostly in relation to the amount of resources that we have available to us. I don't like, there are so many mental health presentations to hospital, and it's just increasing. And I don't know how practical it is to collect EEGs, functional MRIs, heart rate variability, genetic panels, family history, like a thorough family history for all the different cousins and biologically related members of the family for every single person that walks through the door. So I guess just in my mind, and also just the manpower that would be required for that too. In my mind, I'm not seeing a world where we have the resources, the manpower, or the money to do that for every single patient, although that does come at a cost for the patient in that we do need to trial multiple different medications. But I suppose for those patients that have been in hospital for a month and they've already had a couple of different antipsychotics that they've tried, and we're really not getting anywhere, we're a bit stuck. I think that's where the potentially, just my opinion, that where we might actually be able to really make some moves with AI and get a better understanding of what's actually going on for this patient.
Our board chair, Elaine Ashworth, has made the comment in the chat that there's also the cost of failed treatments to consider. So it's not that's not unsubstantial amount of funding for failed treatments, and so that raises the issue for me, where you were talking about validation, and you're talking about RCTs. The field of psychiatry, again, is bedeviled by the natural variation in illness and the relatively low levels of cure in conditions. How do you think, given that we have that situation as our gold standard, how do we then compare the results of a chatbot saying, well, it was equivalent to CBT by a therapist, but the results of CBT for a lot of conditions are not that fantastic. So that doesn't necessarily fill me with great joy about how good the chatbot is. How do we overcome that issue in psychiatry of the relapsing, remitting, unpredictability, and in general poor capability of eliminating illness?
So you're right in that a lot of these, especially more severe psychiatric conditions, do tend to recur. But I suppose there are lots of conditions in medicine that are incurable, but tend to have worse, like exacerbations, right? Like diabetes, they get admitted for diabetic ketoacidosis, and you just treat the diabetic ketoacidosis, but it doesn't cure their diabetes. I suppose in terms of the interpersonal variability, I think it is very personalized, and I think I would just have to take it a case by case basis. Like if I think someone's got they're quite motivated, and maybe there are geographical limitations that prevent them from accessing a psychotherapist, and I think that they're relatively simple. I don't think that there's an underlying, like there's not a lot of developmental trauma and not a personality disorder that's relevant to them. Maybe they just have a bit of anxiety and it's quite simple. I think potentially you could offer a chatbot, you could offer psychotherapy, and I think leaving it to them about what they think, like maybe they try with the chatbot for a little bit and see how it goes, or maybe you can do the referral to the psychologist, but then use the chatbot in the meantime during that 6-month wait when you're waiting for an appointment, to help supplement and support them in the meantime. And then maybe by the time the appointment comes around, they have actually had improvement. But yeah, in general, I think gold standard is still certainly getting that face-to-face therapy. Chatbots are quite simple and they're not able to appreciate that level of complexity, and there might be something underlying there that cannot be identified by a chatbot. But I think that it is another, I suppose, tool in the toolkit for us living rural and needing to treat these patients that maybe don't have the same resources available to them.
Yeah, no, thank you for that. You raised also the issue of population biases, and so I raised the issue of cultural biases, and particularly for cultures with smaller populations, and therefore not the ability to necessarily have that unsupervised learning within their population. How do we apply AI to those smaller numerical populations in our rural towns?
I think that's a very challenging problem. I would be cautious about developing AI on those small populations, just because you do tend to need a lot of data. And I think the smaller the population that you're training the AI on, the higher the risk of encountering problems like overfitting, and the higher the likelihood that there might be unique population differences that might affect that particular town. So the utility may not necessarily be as broad. I suppose my only answer to that would be, when we are using these algorithms, to just keep that in mind. And I suppose we can use it to help inform our clinical judgment, but in the end, it shouldn't trump our clinical judgment. And we should really be mindful of some of those limitations, so that if it does come up with something a bit weird, we can identify that, okay, maybe this is not an actual reliable suggestion, or this is not, taking the recommendations with a grain of salt, I suppose, in those less applicable situations.
Yeah, no. It does raise the issue for me of whether the rich are going to get richer and the poor are going to get poorer in terms of being able to access the benefits of AI for that reason, just for that overfitting or undertraining reason, which is a potentially significant condition. So just looking at my face, you'll see that I have features of a cyborg or a transhuman. I'm wearing glasses. Without glasses, my vision would not be as good. So I'm that combination of technology and human, and a lot of us are now. Most adults are a combination of technology and human. We wear watches now. But this, of course, the combination of doctor and AI somehow seems a lot more scary than doctor wearing glasses or doctor using a computer to type on, etc. Where do you see it? Where do you think it's going to go in your practicing lifetime?
For me personally, I think doing this research has just made me extremely aware of the limitations of AI, and it's made me distrust it even more. And like AI will only get better and more sophisticated and more trustworthy as time goes on. And I do know, and there are certainly applications of AI where it undoubtedly is going to be helpful, right? Like, for example, in scribing or in appointment scheduling, all the administrative stuff. Certainly AI can streamline that a lot more, and it doesn't have much clinical impact on patients. But in terms of making clinical decisions, I think I would have to feel more confident, I think, than I do now in AI before I start using AI to make personalized recommendations. I think the research would need to be a lot more developed, and before I feel confident, especially with all of those population biases and things like that. The part of AI research that I'm most excited for is understanding psychiatric conditions better, and having more of a precise understanding of like what's actually going on for the patient, so that we can be more targeted and it doesn't feel like we're just giving everyone quetiapine.
I think that's a fantastic place for us to finish, Kaitlin. A really informed caution about the overzealous utilization of AI, and also an informed optimism about how this might improve our diagnostic formulations, our nosology, our categorization, and therefore hopefully the personalization of therapy and the better therapy. In the end, better outcomes for all of our people. Thank you so much for sharing with us that deep dive into AI, into the language of language, large language models, and to the potential benefits and risks of transhumanism in medicine. Thank you also to everyone who's been part of this today. It's been a great opportunity for us to think about what is the place of AI in our LHN. And many of you will know that we are exploring the use of AI in mental health with research projects in our LHN right at the moment, as well as utilising it in diabetic ulcer management. And so there's definitely going to be work on it, and it's great to have this overview. Thank you very much, Kaitlin, and all the best with working out where in your future this best sits. Thank you, everyone, and we will meet again at our next grand round, and in the Ngarrindjeri tradition, Nakam. We will see you later.